Welcome to study session 11, Common Psychological Disorders. Introduction. The DSM-5 defined mental disorder as a syndrome characterized by clinically significant disturbance in an individual's cognition, emotional regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. Mental disorders are usually associated with significant distress in social, occupational, or other important activities. In this study session, you will be introduced to neurodevelopmental disorders, depressive disorders, anxiety disorders, obsessive compulsive and related disorders, feeding and eating disorders, and paraphilic disorders. Learning outcomes. At the end of this study session, you should be able to 1. Define neurodevelopmental disorders. 2. Discuss depressive disorders. 3. Describe anxiety disorders. 4. Explain obsessive compulsive and related disorders. 5. Define feeding and eating disorders. 6. Explain paraphilic disorders. Neurodevelopmental disorders. Neurodevelopmental disorders are deficiencies of the growth and development of the brain or central nervous system. They are disorders associated with widely varying degrees of difficulty which may have significant mental, emotional, physical, and economic consequences for individuals and in turn their families and society in general that unfolds as the individual grows. Disorders categorized within neurodevelopmental disorders include A. Intellectual developmental disorders, B. Communication disorders, C. Autism spectrum disorder, D. Attention deficit or hyperactivity disorder, then E. Motor disorders. A. Intellectual developmental disorders. Intellectual developmental disorders has the following properties which are listed below. 1. Intellectual disability. 2. Global developmental delay. 1. Intellectual disability is the term used by the DSM as a more contemporary and commonly acceptable replacement for the term mental retardation which was used in DSM-4. According to the DSM-5, intellectual disability, intellectual developmental disorder, is a disorder with onset during the developmental period that includes both intellectual and adaptive functioning deficits in conceptual, social, and practical domains. For intellectual disability to be diagnosed, the following 3 criteria must be met. A. Deficits in intellectual functions. B. Deficit in adaptive functioning. Then C. Onset of intellectual and adaptive deficits during the developmental period. A. Deficits in intellectual functions, such as reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience, confirmed by both clinical assessment and individualized standardized intelligence testing. Deficits in intellectual functions are determined by using standardized and culturally appropriate IQ tests. A score of approximately 2 standard deviations below average represent a significant cognitive deficit. These scores would occur about 2.5% of the population, or stated differently, 97.5% of people of the same age and culture would score higher. This is typically the IQ score of 70 or below. B. Deficits in adaptive functioning. This results in failure to achieve developmental and socio-cultural standards for personal independence and social responsibility. Without ongoing support, the adaptive deficits limit functioning in one or more activities of daily life, such as communication, social skills, personal independence, school or work functioning. Communication refers to the ability to convey information from one person to another. Communication is conveyed through words and actions. It involves the ability to understand others and to express oneself through words or actions. Social skills refer to the ability to interact effectively with others. We usually take social skills for granted. However, these skills are critical for success in life. These skills include the ability to understand and comply with social rules, customs, and standards of public behavior. This intricate function requires the ability to process figurative language and detect unspoken cues, such as body language. C. Onset of intellectual and adaptive deficits during the developmental period. These limitations occur during the developmental period. This means problems with intellectual or adaptive functioning were evident during childhood or adolescence. If these problems began after this developmental period, the correct diagnosis would be neurocognitive disorder. For instance, a traumatic brain injury from a car accident will cause similar symptoms. The various levels of severity, mild, moderate, severe, and profound, in intellectual disability are defined on the basis of adaptive functioning in the three domains of social, conceptual, and practical skills, and not IQ scores, because it is adaptive functioning that determines the level of support required. 2. Global developmental delay. This is a term used to describe a generalized intellectual disability that is usually characterized by lower than average intellectual functioning, along with significant limitations in at least two other areas of development. Common signs of global developmental delay. 1. Delayed acquisition of milestones. For example, sitting up, crawling, walking. 2. Limited reasoning or conceptual abilities. 3. Poor social skills and judgment. 4. Aggressive behavior as a coping skill. 5. Communication disabilities. All these aforementioned in the table above pertain to those under the age of 5 years whose intellectual functioning. All these aforementioned in the table above pertain to those under the age of 5 years whose intellectual functioning cannot be systematically assessed. Global developmental delay has many causes, which as an end result affect the functioning of the central nervous system. Causes can be any of the listed below. 1. Genetic. 2. Metabolic. 3. Parental. 4. Perinatal. For instance, prematurity or the result of a childhood injury or injection. Sometimes the cause for the condition is undetermined. B. Communication disorders. A communication disorder is any disorder that affects somebody's ability to communicate. The delays and disorders can range from simple sound substitution to the inability to understand or use one's native language. Communication disorder has the following types: language disorder, speech sound disorder, childhood onset fluency disorder, social pragmatic communication disorder. 1. Language disorder. The diagnostic criteria for language disorder include persistent difficulty in the acquisition and use of language across modalities, that is, spoken, written, sign language, or other, due to deficits in comprehension or production, and language abilities that are substantially and quantifiably below age expectations. 2. Speech sound disorder, previously phonological disorder. The key diagnostic criterion for speech sound disorder includes persistent difficulty with speech sound production that interferes with speech intelligibly or prevents verbal communication of messages. 3. Childhood onset fluency disorder, stuttering. The diagnostic criteria for childhood onset fluency disorder, stuttering, are disturbances in the normal fluency and time patterning of speech, and the disturbance causes anxiety about speaking. 4. Socio-pragmatic communication disorder. Socio-pragmatic communication disorder, SCD, is a new diagnosis for DSM characterized by persistent difficulty with verbal and non-verbal communication that cannot be explained by low cognitive ability. Symptoms include difficulty in the acquisition and use of spoken or written language, as well as problems with inappropriate responses in conversation. It includes deficits in using communication for social purposes, impairment in the ability to change communication to match context or the needs of the listener, difficulties following rules of conversation and storytelling, and difficulties understanding what is not explicitly stated and ambiguous meaning of language. See Autism Spectrum Disorder, ASD. Autism is a neurodevelopmental disorder which, according to DSM-5, is characterized by persistent deficits in social communication and social interaction across multiple contexts, as manifested by deficits in social emotional reciprocity, deficits in nonverbal communicative behavior used for social interaction, and deficits in developing, maintaining, and understanding relationships. Severity is based on the following listed below. 1. Social communication impairments are restricted. 2. Repetitive patterns of behavior. 3. Restricted repetitive patterns of behavior. 4. Interests or activities as manifested by at least 2 of 1. Stereotype or repetitive motor movements. 2. Use of objects or speech, for example, simple motor stereotypes, lining up toys or flipping objects, idiosyncratic phrases. 3. Insistence on sameness. 5. Inflexible adherence to routines or ritualized patterns of verbal or non-verbal behavior. For example, extreme distress at small changes, difficulties with transitions, rigid thinking patterns, greeting rituals, need to make same route or eat same food every day. 6. Highly restricted, fixated interests that are abnormal in intensity of focus. For example, strong attachment to or preoccupation with unusual objects, excessively circumscribed or perseverative interests. And 7. Hyper or hypo-reactivity to sensory input or unusual interest in sensory aspects of the environment. For example, apparent indifference to pain or temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, usual fascination with lights or movement. D. Attention deficit hyperactivity disorder, ADHD. ADHD is a neurodevelopmental disorder that begins in childhood and can continue through adulthood for some people. ADHD is characterized by a pattern of behavior present in multiple settings, for example, school and home, that can result in performance issues in social, educational, or work settings. Symptoms are divided into 2 categories of inattention and hyperactivity and impulsivity that include behaviors like failure to pay close attention to details, difficulty organizing tasks and activities, excessive talking, fidgeting, or an inability to remain seated in appropriate situations. Children must have at least 6 symptoms from either or both the inattention group of criteria and the hyperactivity and impulsivity criteria while older adolescents and adults over 17 years must present with 5. Using DSM-5, several of the individual's ADHD symptoms must be present prior to age 12 years compared to 7 years as the age of onset in DSM-4. To be diagnosed with ADHD, DSM-5 requires that people with ADHD show a persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning or development. Symptoms of inattention can be observed in an individual who often fails to give close attention to details or making careless mistakes in schoolwork, at work, or with other activities, has trouble holding attention on tasks or play activities, seems not to be listening when spoken to, fails to follow through on instructions, and fails to finish schoolwork. To be diagnosed of inattention, children up to age 16 must have 6 or more symptoms of inattention. Adolescents 17 and older and adults must have at least 5 symptoms. Also, these symptoms of inattention must have been present for at least 6 months and are deemed inappropriate for individuals' developmental level. Symptoms of hyperactivity and impulsivity can be seen in an individual who often fidgets with or taps hands or feet, or squirms in seat, leaves seat in situations when remaining seated is expected, runs about or climbs in situations where it is not appropriate. Adolescents or adults may be limited to feeling restless. To be diagnosed with hyperactivity and impulsivity, 6 or more symptoms of hyperactivity, impulsivity must be present in children up to age 16 or 5 or more in adolescents 17 years older and adults. Also, these symptoms of hyperactivity, impulsivity must have been present for at least 6 months to an extent that is disruptive and inappropriate for the person's developmental level. Motor disorders. Motor disorders are disorders of the nervous system that cause abnormal and involuntary movements. They can result from damage to motor systems. DSM-5 defines it as a new subcategory of neurodevelopmental disorders. Types of motor disorders. Motor disorders have 3 types, which are: 1. Developmental coordination disorder. 2. Stereotypic movement disorder, SMD. 3. Tic disorders. 1. Developmental coordination disorder. The acquisition and execution of coordinated motor skills is substantially below that expected from the patient's age and opportunities for learning. Clumsiness, dropping or bumping into objects, and slow, inaccurate performance of motor skills. Catching objects, handwriting, using utensils, bicycle riding, or participation in sports. The diagnosis is made by synthesis of the developmental and medical history, physical and neurological examination, report from school or workplace, and appropriate psychometric assessment. NDSM-5 Criterion A. Impaired coordination is manifested differently at different ages. Delayed motor milestones in some very young children. Delay in acquiring or slowness and inaccuracy in performing skills such as stair climbing or buttoning in older children, and slowness or inaccuracy in typing or handwriting or athletic pursuits in adolescence and adulthood. Criterion B. Impairment of motor skills interferes with daily activities. Is necessary for the diagnosis. Take 2. Is necessary for the diagnosis. The disorder is not better accounted for by intellectual disabilities, visual problems, or a neurological condition such as cerebral palsy, or a degenerative disorder. 2. Stereotypic movement disorder, SMD. This is a motor disorder with onset in childhood involving repetitive, non-functioning motor behavior that markedly interferes with normal activities or results in bodily injury. The behavior must not be due to the direct effects of a substance or another medical condition. Common repetitive movements of SMD include head banging, arm waving, hand shaking, rocking and rhythmic movements, self-biting, self-hitting, skin picking. Other stereotypes are thumb sucking, nail biting, trichotillomania, bruxism, and abnormal running or skipping. 3. Tic disorders. Tics are sudden twitches, movements or sounds that people do repeatedly. People who have tic cannot stop their body from doing such things. A person can exhibit a motor tic, such as blinking or shrugging the shoulders, or a vocal tic, such as humming, grunting, clearing the throat, or yelling out a word or phrase unwillingly. 3 tic disorders are included in the DSM-5, which are Tourette's disorder, also called Tourette's syndrome, TS. 2. Persistent or chronic motor or vocal tic disorder. 3. Provisional tic disorder. The tic disorders differ from each other in terms of the type of tic present, motor or vocal, or a combination of both, and how long the symptoms have lasted. According to DSM-5, people with Tourette's syndrome have at least 2 motor or at least 1 vocal tics together, which may not always happen at the same time, and have had tic symptoms for at least 1 year, which can occur many times a day, usually in bouts, nearly every day, or on or off. People with persistent motor or vocal tic disorders have not been diagnosed with TS, have either motor or vocal tics, and have had tic symptoms for at least 1 year, which can occur many times a day, nearly every day, or off and on. People with provisional tic disorders, formerly transient tic disorder in DSM-4, can have motor or vocal tics or both, but have had their symptoms less than 1 year. Depressive disorders. A depressive disorder is an illness that involves the body, mood, and thoughts. It interferes with daily life, normal functioning, and causes pain for both the person with the disorder and those who take care about him or her. A depressive disorder is not the same as a passing blue mood. It is not a sign of personal weakness or a condition that can be willed or wished away. People with a depressive illness cannot merely pull themselves together and get better. Without treatment, symptoms can last for weeks, months, or years. Depression is a common but serious illness, and most people who experience it need treatment to get better. Appropriate treatment, however, can help most people who suffer from depression. Depressive disorders come in different forms, just as is the case with other illnesses such as heart disease. Disorders grouped among the depressive disorders in the DSM-5 are listed and discussed below. 1. Disruptive mood dysregulation disorder. This is a new DSM disorder characterized by severe recurrent temper outbursts and persistent negative mood for at least 1 year, beginning before age 10. 2. Major depressive disorder. The cardinal symptoms of major depressive disorder include profound sad mood and or loss of pleasure. In addition to these, the DSM-5 requires the person to be diagnosed as depressed must also experience at least 3 of sleeping too much or too little, psychomotor retardation or agitation, weight loss or change in appetite, loss of energy, feelings of worthlessness or excessive guilt, difficulty concentrating, thinking or making decisions, and recurrent thoughts of death or suicide. The symptoms are present nearly every day, most of the day for at least 2 weeks. The new inclusion of bereavement-related symptoms in the diagnosis of major depressive disorder, which was excluded in DSM-4, has been the focus of several debates. 3. Persistent depressive disorder. Dysthymia. Depressed mood and at least 2 other symptoms of depression: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, feelings of hopelessness. For most of the day, more than half of the time for 2 years, at least 1 year for children and adolescents. 4. Premenstrual dysphoric disorder. This is a new DSM disorder characterized by significant distress or functional impairment in the week before menses in most menstrual cycles during the past year, involving at least 5 of 1. Affective liability, 2. Irritability, 3. Depressed mood, hopelessness or self-depreciating thoughts, 4. Anxiety, diminished interest in usual activities, 5. Lack of energy, 6. Changes in appetite, overeating or food craving, 7. Sleeping too much or too little, 8. Subjective sense of being overwhelmed or out of control, 9. Physical symptoms such as breast tenderness or swelling, joint or muscle pain or bloating, and improves within few days of menses onset. Anxiety disorders. The experience of anxiety and fear is common among many. Though these terms are often used as synonymous, they are not exactly the same. While anxiety is basically an apprehension over an anticipated future problem, fear is a reaction to immediate danger. Thus, a person who sees a snake and is frightened is experiencing fear, while a student who is concerned about the possibility of getting a good job after graduation is experiencing anxiety. Both anxiety and fear involve sympathetic nervous system arousal, though at different levels. Anxiety involves moderate arousal of restless energy and physiological tension, while fear involves higher arousal of profuse sweating, rapid breathing, and an overpowering urge to run. Though anxiety and fear may appear bad, they are actually necessary for our survival. Fear enables us to respond promptly and appropriately in times of exposure to danger, while anxiety helps us to prepare for future eventualities by thinking through potential problems before they happen and guiding against their happening. There are various types of anxiety disorders, and the symptoms of each must meet the DSM-5 criteria of interfering with important areas of functioning or cause marked distress, not being due to a drug or a medical condition, and the fears and anxieties are distinct from the symptoms of another anxiety disorder. A. Separation anxiety disorder. An individual with separation anxiety disorder, SAD, experiences clinically significant distress or impairment in social, academic, occupational, or other important areas of functioning from a developmentally abnormal level of persistent anxiety in response to separation or impending separation from an attachment figure. Under DSM-5, SAD is defined as separation anxiety disorder that persists in individuals under 18 for at least 4 weeks and adults for 6 months or more, as evidenced by 3 of the following symptoms: recurrent excessive distress when anticipating or experiencing separation from home or major attachment figures. B. Selective mutism, Children and adults with selective mutism are fully capable of speech and understanding language, but fail to speak in certain situations, though speech is expected of them. The behavior may be perceived as shyness or rudeness by others. A child with selective mutism may be completely silent at school for years, but speak quite freely or even excessively at home. Selective mutism is by definition characterized by a consistent failure to speak in specific social situations in which there is an expectation for speaking, for example at school, despite speaking in other situations. The disturbance interferes with educational or occupational achievement or with social communication. The duration of the disturbance is at least 1 month, not limited to the first month of school. The failure to speak is not due to lack of knowledge of or comfort with the spoken language required in the social situation. The disturbance is not better accounted for by a communication disorder, for example stuttering, and does not occur excessively during the course of a pervasive developmental disorder, schizophrenia, or other psychotic disorder. C. Specific phobia. The DSM-5 criteria for specific phobia include avoidance of specific objects, snakes, spiders, and blood, or situations, climbing heights, crowd, that consistently trigger marked and disproportionate fear for at least 6 months. The names of these fears consist of a Greek word for the fear object or situation followed by the suffix phobia, derived from the name of a Greek god Phobos, who frightened his enemies. Examples of some specific phobias are claustrophobia, fear of closed spaces; mosophobia, fear of mice; acrophobia, fear of height; xenophobia, fear of spiders, and so on. D. Social anxiety disorder, social phobia. This term was formerly called social anxiety disorder in the DSM-4. It's a persistent, unrealistically intense fear of social situations that might involve being negatively evaluated, resulting in such situations being avoided or else endured with intense anxiety. The symptom must persist for at least 6 months. The most common fears include public speaking, meeting new people, speaking at meetings or classes, and so on. E. Panic disorder. Panic disorder is characterized by frequent panic attacks that are unrelated to specific situations and by worry about having more panic attacks. A panic attack is a sudden attack of intense apprehension, terror, and feelings of impending doom, accompanied by at least 4 other symptoms. Physical symptoms can include labored breathing, heart palpitations, nausea and upset stomach, chest pain, feeling of choking and smothering, dizziness, lightheadedness, sweating, chills, heat sensation, and trembling. Other symptoms that may occur during a panic attack include depersonalization, a feeling of being outside one's body; derealization, a feeling of the world not being real; and fear of loss of control, of going crazy, or even dying. Panic attacks that occur unexpectedly are called uncued attacks, while those triggered by specific situations are referred to as cued panic attacks. People who only have cued attacks are most likely to suffer a phobia. The DSM criteria require that a person must experience recurrent uncued panic attacks for a diagnosis of panic attack to be made. They also must worry about the attack or change their behavior because of the attacks for at least 1 month. Hence, the response to the attack is as important as the attacks themselves in making this diagnosis. Obsessive, compulsive, and related disorders. Obsessive compulsive disorder, OCD, is characterized by obsessions, recurrent, intrusive, and disturbing ideas, thoughts, impulses, or images, as well as compulsions, repetitive behaviors, or mental acts performed according to certain rules or in a stereotyped fashion designed to reduce discomfort, and may be severe enough to be time-consuming or cause marked distress or significant functional impairment. Key features of obsessive compulsive disorder in the DSM-5 include repetitive, intrusive, uncontrolled thoughts or urges, obsessions, repetitive behaviors or mental acts that the person feels compelled to perform, compulsion. The most frequent foci of obsessions include fear of contamination, sexual or aggressive impulses, body problems, religion, and so on. Compulsions include carrying out ritualistic behavior for fear that something bad will happen if the act is not performed. Forms of obsessive compulsive disorder: body dysmorphic disorder, hoarding disorder, trichotillomania, hair pulling disorder, exfoliation, skin picking disorder. A. Body dysmorphic disorder. This is characterized by preoccupation with an imagined flaw in one's appearance and excessive repetitive behaviors or acts regarding appearance, such as checking appearance or seeking reassurance. B. Hoarding disorder. This new DSM-5 diagnosis is marked by the acquiring of excessive number of objects with the inability to part with the objects. The symptoms result in the accumulation of a large number of possessions that clutter key areas in the home or workplace to the extent that their intended use is no longer possible unless others intervene. C. Trichotillomania, hair pulling disorder. DSM-5 places trichotillomania in the category of obsessive, compulsive, and related disorders that it is characterized by recurrent body-focused repetitive behavior, hair pulling, and repeated attempts to decrease or stop the behavior. The behavior can occur during both relaxed and stressful times, but there is often a mounting sense of tension before hair pulling occurs, or when attempts are made to resist the behavior. The specific DSM-5 criteria for trichotillomania hair pulling disorder include recurrent pulling out of one's hair resulting in hair loss, repeated attempts to decrease or stop the hair pulling behavior. Hair pulling causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The hair pulling or hair loss cannot be attributed to another medical condition, for example, a dermatologic condition, and the hair pulling cannot be better explained by the symptoms of another mental disorder. For example, attempts to improve a perceived defect or flaw in appearance, such as may be observed in body dysmorphic disorder. D. Exfoliation, skin picking disorder. Exfoliation, skin picking disorder is characterized by recurrent skin picking resulting in skin lesions. Individuals with exfoliation disorder must have made repeated attempts to decrease or stop the skin picking, which must cause clinically significant distress or impairment in social, occupational, or other impairment areas of functioning. The skin picking cannot be attributed to the physiologic effects of a substance or another medical condition. The skin picking cannot be better explained by the symptoms of another mental disorder. Feeding and eating disorders. The subject of food and eating is one that preoccupies many in our world. People are also concerned about gaining too much weight, leading to obesity, while others seek to diet in order to lose weight. There are different types of feeding and eating disorders which are listed below. A. Picker. B. Rumination disorder. C. Avoidant restrictive food intake disorder. D. Anorexia nervosa. E. Binge eating disorder. A. Picker. Eating non-food substances for a period of at least 1 month. The eating behavior is not culturally sanctioned. Individuals with picker may consume a variety of non-nutritive substances, including mud, pottery, clay, and laundry starch. Picker eating of numerous other substances such as paper, tissues, wood, plastic straws, soap, cloth, carpet, hair, string, wood, paint, gum, metal, pebbles, chalk, has also been reported. B. Rumination disorder. Rumination disorder is an eating disorder in which a person, usually an infant or young child, brings back up partially digested food and then swallows it again or spits it out. To be considered a disorder, this behavior must occur in children who had previously been eating normally, and it must occur on a regular basis, usually daily, for at least 1 month. The child may exhibit the behavior during feeding or right after eating. Symptoms of rumination disorder in babies and young kids include repeated regurgitation of food, with or without rechewing of food, weight loss, bad breath and tooth decay, repeated stomach aches and indigestion, raw and chapped lips. C. Avoidant restrictive food intake disorder. Previously defined as a disorder exclusive to children and adolescents, the DSM-5 broadened the disorder to include adults who limit their eating, but not as a result of unavailability of food. Neither is it due to observation of cultural norms. The disorder includes disturbance in eating or feeding, as evidenced by one or more of substantial weight loss, or in children, absence of expected weight gain, nutritional deficiency, dependence on a feeding tube or dietary supplements, and significant psychosocial interference. D. Anorexia nervosa. The term anorexia refers to loss of appetite, and nervosa indicates that the loss is due to emotional reasons. The term is, however, a misnomer, as most people with anorexia nervosa actually do not lose their appetite of interest in food, but rather most people with a disorder become preoccupied with food and may even read cookery books constantly and prepare nice meals for their families. The disorder is often marked by restriction of food to promote healthy weight, even though body weight is significantly below normal, accompanied with intense fear of weight gain and body image disturbance. E. Binge eating disorder. This has been moved from condition in need of further study in DSM-4 to recognized diagnosis in DSM-5. Binge eating includes recurrent binges of at least once per week for at least 3 months, involving at least 3 of eating more quickly than usual, eating until overfull, eating large amounts even if not hungry, eating alone due to embarrassment about large food quantity, feeling bad, for example, disgusted, guilty, or depressed after the binge. There is no compensatory behavior present. It is distinguished from anorexia nervosa by the absence of weight loss, and from bulimia nervosa by absence of compensatory behavior. Most people with binge eating disorder are obese, having a BMI greater than 30, but not all obese people meet the criteria for binge eating disorder. Paraphilic disorders. Humans are sexual beings with divergent private sexual preferences and fantasies, some of which may be shocking. These sexual fantasies and preferences are ordinarily no problems until they cause marked distress or impairment to the individual, or when the individual engages in sexual activities with non-consenting persons. In DSM-5, paraphilic disorders are defined by persistent and troubling sexual attractions to unusual objects or sexual activities lasting at least 6 months, which often cause significant distress and impairment in functioning. These are different types of paraphilic disorders distinguished on the basis of the source of sexual arousal. This disorder is more common among men than women. A. Voyeuristic disorder. B. Exhibitionist disorder. C. Frotteuristic disorder. D. Sexual masochism disorder. E. Sexual sadism disorder. F. Pedophilic disorder. G. Fetishistic disorder. H. Transvestic disorder. A. Voyeuristic disorder. This disorder involves an intense and recurrent desire to obtain sexual gratification by watching unsuspecting others who are naked, undressing, or having sex, and the individual must have acted on this desire with at least 3 unsuspecting persons on separate occasions, or the urges and fantasies cause marked distress or interpersonal problems. B. Exhibitionistic disorder. This disorder involves a compulsive and distressing desire to expose one's genitals to an unwilling stranger, and the individual must have acted on this desire with at least 3 strangers on separate occasions, or the urges and fantasies cause marked distress or interpersonal problems. Frotteuristic and voyeuristic disorders are very common in exhibitionists. C. Frotteuristic disorder. This involves an individual sexually oriented towards touching or of rubbing against an unsuspecting person, and the individual must have acted on this desire with at least 3 non-consenting persons on separate occasions, or the urges and fantasies cause marked distress or problems. The frotteur may rub his genitals against a woman's thigh or buttock, or fondle her breasts or genitals. These acts usually occur in places such as a crowded bus or crowded areas that include an opportunity to rub against unsuspecting persons. D. Sexual masochism disorder. This disorder is defined by an intense and recurrent desire to obtain or increase sexual gratification by receiving pain or humiliation. The manifestation of this disorder include physical bondage, blindfolding, spanking, whipping, and so on. Most sadists establish relationships with masochists to derive mutual sexual gratification, although many people can change roles. E. Sexual sadism disorder. This disorder is defined by an intense and recurrent desire to obtain sexual gratification by inflicting pain or psychological suffering on another, and the individual has acted on these urges with at least 2 non-condensing others on separate occasions. F. Pedophilic disorder. This disorder is diagnosed when adults derive sexual gratification through sexual contact with children, or when the sexual arousal is as strong or stronger for children than for adults, or when they experience recurrent, intense, and distressing desires for sexual contact with children, or have repeatedly gained more arousal from child pornography than from pornography depicting mature persons for at least 6 months. DSM requires that the offender be at least 18 years old, or at least 5 years older than the child. Summary of study session. In this study session, you have learned that 1. Neurodevelopmental disorders are deficiencies of the growth and development of the brain or central nervous system. 2. A depressive disorder is an illness that involves the body, mood, and thoughts. 3. Anxiety involves moderate arousal of restless energy and physiological tension, while fear involves higher arousal of profuse sweating, rapid breathing, and an overpowering urge to run. Though anxiety and fear may appear bad, they are actually necessary for our survival. 4. Obsessive compulsive disorder, OCD, is characterized by obsessions, recurrent, intrusive, and disturbing ideas, thoughts, impulses, or images. 5. The subject of food and eating is one that preoccupies many in our world. People are also concerned about gaining too much weight, leading to obesity, while others seek to diet in order to lose weight. 6. In DSM-5, paraphilic disorders are defined by persistent and troubling sexual attractions to unusual objects or sexual activities lasting at least 6 months, which often cause significant distress and impairment in functioning. We have come to the end of study session 11. Thank you.